been asked to talk about the heart, and I'd like to give you kind of a general overview about the heart in general. Heart disease kills 492,000 people a year in the United States every year. It is the #1 cause of death. It is equal and slightly higher than if you added up all cancer deaths in the United States. It's still, they're about the same. They're both #1 and 2. They kind of switch places, but to consider that large number, it's very important to identify who's at risk for heart disease and who's not. Because it's so prevalent, we need to understand what goes into heart disease. And so I always like to begin this kind of talk with what happens during a heart attack. Okay? And so let's just say that, this is an artery in your heart. Okay? So arteries have blood in them, but they also have cholesterol that we all know that floats around through your body. And over time, calcium likes to stick to the walls of your arteries. Okay? If you have too high cholesterol, over time you'll get this kind of layer of cholesterol, and as it builds over time, you're getting layer upon a layer of cholesterol formed in your heart. Okay? So we know this happens, and your body, when it sees this kind of cholesterol sticking to it, tends to form this little protective coating over each layer of cholesterol. So your body tolerates cholesterol fine as it's floating in here, and it eventually tolerates it to the point here. But what happens during a heart attack is that this wall that's blocking the cholesterol or kind of keeping it stuck to the wall gets a crack in it. Okay? So when you get a crack in this cholesterol wall, your cholesterol kind of squirts out. When your cholesterol squirts out, your body, even though it likes it here, it doesn't like the fact that there's a bolus of it sticking right here. And so when this happens, your body decides, I'm going to form a big clot like this. So you form this giant clot within a matter of minutes, okay, starting from this blockage. Okay, so you look right here, you have an artery, that's this, and you have a blockage here, that's only 20, 30, 40% blockage. Okay, because even blockage is this small sometimes can't rupture, cause the rest of it to clot off. So that happens during the heart. So the whole goal of medicine with heart disease is obviously how do you stop this from happening? Well, we control blood pressure because there's blood coming through here. The higher the pressure is through this artery, you're battering this piece of blockage. Right? So every time you hit it, the harder you hit it, the more likely this thing's going to crack open. So we give medications to lower blood pressure, keep it from happening. Okay? We give obviously cholesterol medications to try to lower the amount of cholesterol in here, so you hopefully won't deposit as much cholesterol here. But there's an added benefit to cholesterol medications because when your body forms this wall of cholesterol, okay, part of your body says this cholesterol is not supposed to be here. So your body says, let's get rid of this cholesterol, so it starts to attack the wall of this blockage anyway. Okay? Well, what that part of your body doesn't know is that if it's successful in drilling a hole through this wall, you're going to break that wall again and start this process from happening. Okay? And that is something, this inflammation that's going on in your body trying to kill it, to try to break through this wall, that's measured by something called C-reactive proteins. If you read about medical journals and they say, well, C-reactive protein is something you should measure as a measure for blockage, okay? That's what they're talking about. That this inflammation is your body trying to destroy this wall. Well, cholesterol medications like Lipitor, Zocor, the things you hear about, those things not only lower this, but they help lower the inflammation along the wall. So they slow your body's process of trying to destroy this. Okay? So it lowers C-reactive protein, it lowers inflammation, so your body doesn't have to do it, and it makes this wall more solid. So it doesn't have to progress or less likely to break open. So we do that too. Okay? And then if you hear about aspirin, aspirin obviously is a blood thinner, so they're trying to prevent this giant clot from happening. So if it does break through, right, you have aspirin to hopefully keep this clot from getting so big or help dissolve it. That's why you hear when you have chest pain, you should chew an aspirin because you want a blood thinner in you to try to keep this thing from growing or trying to dissolve it as quickly as possible. Right? So we have different kinds of medications, blood pressure, lower here, aspirin here, and you have cholesterol medications here. So we have all these issues of treating it, but it lies, the important thing is, well, yeah, we have these things to treat it. How do we know whether you have it or not? Right? Who needs these kind of medications? Who doesn't? And who's at risk, right? So the major risk factors of heart disease are what you know. Genetics, unfortunately, play a large role. What your parents have, high blood pressure, high cholesterol, smoking, all these things do. Smoking in particular causes inflammation in your arteries. So it causes inflammation here, so it may be more likely for these things to break open. So heart disease does that as well. And if this happens in your brain, the same thing happens. You have a stroke. If there's anything happens there, or happens in your legs, you can have a blockage in your legs, blood flow there, you can have a problem. All these arteries are the same. So the heart disease just happens to be the most common of all these things. So I've always been, you always identify the traditional risk factors, but you have to understand that 50% of all people who have their first heart attack have normal cholesterol. So half of them have normal cholesterol. Well, then how do you know if their cholesterol is normal? Do they have any kind of risk? Right? So there are multiple screening tests that we do for heart disease. And the classic ones everybody knows about getting EKGs for a physical. You do a stress test on people during these to identify problems. Well, when you look at the data that looks at heart disease, when you go for your physical, EKGs are, when you're not having any problems, are basically worthless. They don't really show a lot as far as about identifying heart disease initially. They do make a lot of difference when you're having chest pain. They do make a difference if you're about to do surgery. There are things like that obviously important, but if you're coming in just for your physical, EKG really does not identify heart disease. Okay? So, and also they've done studies that said, should you get a stress test every year or every other year when you have, if you don't, this is all the people who don't have any known heart disease. Okay, so you go to the doctor, you get your physical and say, should I get a stress test? You're not having any pain. Well, if you do that, that also is statistically worthless. They don't identify the people effectively. It's not what we call a cost-effective study, because 99% of the time, those stress tests are going to be normal if you don't have any kind of problem, and if you don't have a known history. So we say, well, these are the tests that we've known for a long time to identify problems, and they are very useful tests when you have problems. If you have chest pain, or trouble breathing, or things like that, those are useful tests. So how do you identify somebody who just walks in and says, I'm here for my physical, I'm feeling fine, what do I need to do about heart disease? Well, there's a test that I've been using and ordering for years called a coronary calcium scan. Okay, this test has been around for about 13 to 15 years. Okay, it is a CAT scan, and it costs about $99. And this test, it's a low-dose radioactive study. Slide through a big donut. It takes 30 seconds. You don't need an IV. You wear your clothes, and you slide through, and it measures the amount of calcium located on the arteries of your heart. Okay. Calcium has been long known to be attracted to blockages in your heart. Okay. So every time you build some cholesterol over here, calcium just loves to stick to it. Little dots of calcium. So it looks like sedimentary rock. You remember from school that you get these little dots of calcium that just layer and layer and layer. Okay? And this happens over years to decades. Okay? So the more blockage you have, the more calcium you have. Okay? And it's not a perfect test, but it gives you a rough estimate of who is at risk. Okay? So what you get with this score, this test is something called a calcium score. The lower the score, the better. If you get a calcium score of 0, that means you have no appreciable blockage in your heart, and I usually do it in 5 years. Okay? If you get a score between 0 and 10, that is minimal blockage. You still need to diet and exercise, but it's nothing to be concerned about then. 10 to 100 shows that you do have blockage. You have blockage in your heart, but the majority of people over the age of 35 have small amounts of blockage in their heart anyway. Okay? But 10 to 100, you really need to watch it with diet, exercise. That's when you start considering aspirin, cholesterol medications, blood pressure management. You should be doing that anyway, but you really need to make sure they have very intensive control at that time. But if the total score, when they add up all the arteries of your heart and look at this thing, is over 100, there's a potential problem. Okay? If the total score is over 100, you you are 7 times more likely to have a heart attack in the next 10 years. If it is over 300, you are 10 times more likely to have a heart attack in the next 10 years. And you roughly have about a 50% chance that you need a stent or bypass now. You don't know. Because the scary thing about heart disease is that people do not have chest pain or trouble breathing or something related to the heart until the arteries are about 85% blocked off. You can have an 80% blockage, you can exercise, feel perfectly fine, and then you can suffer a massive heart attack if that thing cracks and you block the rest of it off. Okay. So that's why this test is very important. I mean, I find about 6 people or so a year, and I found 3 in the last few weeks that came for their physical. They feel perfectly fine. They came back, their calcium scores are abnormal. If it's abnormal, then you do a stress test, which is useful. Or in some of those people's cases, their calcium scores were so high that I knew a stress test was going to be abnormal. I went ahead and sent them to the cardiologist to get a heart cath, and they've had their stent and their bypass. These are people that are walking around. So this, everybody knows about somebody that's had, they were fine, their exercise, and all of a sudden they dropped dead. And then they get their autopsy to find out. It's because heart disease is very silent. It's not like, skin cancer where you can look on your skin, but things get kind of bigger. It's very silent. You'll never see it until you go looking for it. And so the traditional tests that we have, yes, they help us, but you really need to have some sort of imaging. To me, this is the single best study for people who don't have any problems, don't have any symptoms. Another thing, if you have known heart disease, okay, those things are, you have to do stress tests on those people. If you already have heart disease, that's another story. This is talking about the general population, try to prevent something, right off the bat. So identification is key. Okay? And then so, if you have your doctor, you should ask about this test. I mean, it's not an expensive test, and I think it's very worthwhile doing. So I like the heart is very important, obviously, but I also want people not to ignore the other things that go along too. Because, like I told you, you have a blockage here. Yeah, that's your heart, but you can have it in your neck. You can have something in your legs or something like that. So these are all, part of the same system. Okay, why, if you have blocked your heart, that you couldn't have it in your neck to give you a stroke, or give you, legs to give you, blocking your legs to cause gangrene or problems like that. So these are all systems, and it's all about screening. And luckily, we also have, better screening tests in hospitals like this one, or other places have screening tests for those diseases as well. And those things I think are very important. The hospital has a lining, which I'm glad they got these for, I think, $90 or $99. They will screen your arteries in your neck. They will look for an aneurysm in your belly, and also screen you for what's called peripheral vascular disease, which is blockages in your legs. Okay? So I like to talk briefly about those things because carotids are important. These are what the same thing for your heart. They prevent you from, hopefully, if they're clear, will keep you from having a stroke. So, and same things happen for those. You don't have symptoms, you can have an 80% blockage, you'll never feel anything, and you can have a stroke. Same thing happens in the lungs. The legs happen, those symptoms with blockages, and these are very in high percentages in diabetics. Diabetics are the number 1. Diabetics and smokers, okay, can have blockages in their legs. And a lot of people don't know what those symptoms are if you have blockages in your legs, and that's called claudication. And it usually starts out with calf pain. Your calves hurt when you walk a certain distance. Okay, so let's say you walk and you go, my calves hurt, and then you stop for a second, for a few minutes or a minute or two, and then the pain goes away, and then you walk again, and the calf starts hurting. It's almost like these people can predict when it's going to happen. But, if I know I walk exactly a block, I will get leg pain. I stop for a minute, and I walk again. Those are classic signs of blockage. Okay, so those people are identified by these kind of screening tests. But it's important to know ahead of time. And that's why I think these tests are good. And the last one with aneurysms. Aneurysms are dilations of your aorta. So your heart's here, and then you have a big artery that comes across like this. Well, an aneurysm is where you have a bulge in your artery. Okay? It's a weakened spot in the wall, and those things can rupture. Okay? Well, aneurysms have no symptoms. There's only one symptom to an aneurysm, and that one symptom that you would ever feel is when it ruptures, and that's about it. Okay, the mortality, the chance of dying when you have a ruptured aneurysm is well over 90% if it happens. Okay? You will never feel it. You can't see it. can't feel it. Sometimes the doctor, the physician can feel an aneurysm if it's big enough. Sometimes I've been able to find it myself that way. But really the best way to screen these things are with ultrasounds. Okay, and the risk factors of those are family histories and smoking, the big risk factors. And a lot of insurances don't really cover these kind of screening tests, but I think it's very important to have those things done too. I can't tell you how many times I've found an aneurysm, and a lot of the times before these screening tests came out, doctors would find an aneurysm by pure chance. You'd be looking for something else. You look at your gallbladder, if you do an ultrasound, you happen to see an aneurysm at the same time. That's what we find the majority of them. But I feel that, it's really, you're missing a lot of things because aneurysms are a lot more common than we have, than you ever would know something. So the whole premise of this thing is that it's all about prevention. Doctors know, and they know what to do once you have heart disease or know when you have cholesterol, and I'm sure everyone's doctor here is more than capable of handling those things. The reason I want you to know is that you need to be proactive in trying to identify whether you're one of these people that need it. Because by the time if you don't get screening early, it's going to be too late. So that's why I think these protocols that we have, these screens you have for